Hi, hello, everybody, and welcome. Thank you for joining us. We're excited to have you back with us today in the sixth and final session for our Burnout 201 webinar series. My name is Mariah Blake, and I'm the program manager here at the Association of Clinicians for the Underserved. Today, Dr. Eileen Barrett is back with us once again to give her thoughts on burnout. We just have a few quick housekeeping items to go over before we get going, so let's get started. All right, just a quick reminder for anybody who's joining us for the first time today and hasn't been with us for previous sessions. My little summary here. This webinar has been produced through the STAR Center, the workforce NCA of the Association of Clinicians for the Underserved. ACU is a national nonprofit focused on the recruitment and retention of clinicians in underserved areas. We do that through projects like the STAR Center. We do that through National Health Service Corps advocacy and training and resources for clinicians of all disciplines. As I just mentioned, we are ACU's Workforce Project. We're funded through a National Cooperative Agreement, an NCA, with HRSA's Bureau of Primary Healthcare. Through this NCA, we're able to create and share resources like this training series and other training opportunities and tools for health center workforce staff, absolutely free of charge. If you're new to the STAR Center, I hope you'll go and learn a bit more about us on our website listed here. It's chcworkforce.org. I've also included the contact information for the entire STAR Center team if you want to follow up with any of us individually. If at any point during this session you have questions, please put them in the chat box. If you have any technical issues, either chat them to me, Mariah Blake, or you can email me at my address listed there, mblake@clinicians.org, and I'll do my best to help you out. We are recording today's session like we have for all of the past sessions in the series. We'll send out a follow-up email probably tomorrow morning with instructions on how to access the recording. You can share that with your team members or revisit something that you really liked about the presentation. And we'll also share out the slides as well so that you can revisit some points there. Like I said, please ask questions throughout. We'll probably save time towards the end of the session to actually address those questions, but I'll do my best to get to anything small as we're going. I will read out your questions at the end of the session for Dr. Barrett to address. And we ask that you have fun. Just take some time and relax with us so that you can come back to your teams after this session ready to address recruitment and retention in your organization. Just a quick little overview of our goals for this whole series. We are at the end, so hopefully we're leaving you at that bottom point there with learning strategies to address burnout. All right, and with that, I will hand the mouse and slide control back over to Dr. Barrett so that she can kick off today's session. Thank you again, everybody, for joining us.
Thank you, Mariah, and thanks so much also for all of the work that you have done and also that ACU and STAR have done. This is really so important to me. And for context, if there's anyone who wasn't present on the previous webinar that I gave, I'm a former National Service Corps scholar. I'm a physician in New Mexico, and this is an issue that, like for you, is near and dear to my heart, and because it's near and dear to our patients and to my colleagues. And so with that, while we think about recruiting and retention, I want us to make sure that we start really with a shared mental model. And this, I would like us to be, that we have just restate some assumptions. So my assumptions that you, when you've taken time out of your busy day, and also when you have really taken the time in your life to be committed to the care of communities and patients and also of clinicians, that I assume that we have similar goals, and so these are the assumptions that I'm making, and I hope that you agree with these statements. The first is that recruiting problems and challenges, they usually start with retention problems, not always, but usually. Next is that new hires, they're usually new graduates who are usually new. They're usually earlier in their career and often will be millennials then. But also, of course, new hires are often new job seekers who were unhappy with their old jobs. And that's why they left, and that's why they were able to come to us. I do know that I'm not addressing people who switched because of family or other duty reasons, but of course, these lessons will apply to them. But those are the first two assumptions. The third is you've spent time on this webinar. I suspect, these webinar series, I suspect that you know and that you believe that burnout can be predicted, but it also can be treated and it also can be prevented. And our hope is that we can prevent it, ideally also through our retention and our recruitment efforts. So then we'll really get into the content. So I thought, because we're going to be having those assumptions that the people who are coming to us for recruitment, that they are people who are often new graduates and they're often early career, and that means that they're often millennials. And I am not a millennial, but I love working with millennials. This is a photograph of a screenshot that was actually in Forbes magazine about millennials and about how hardworking they are and how perfectionist oriented they are. I think we should note a few things, because in sort of popular culture or in common lexicon, people can speak disparagingly about millennials, and I happen to not agree. And I should note that, of course, we shouldn't be monolithic. People are individuals, of course, but when people speak about generations, there are some stereotypes about millennials. But I will ask you to also understand a few things about millennials. One of them is to understand that they are nearly digitally naive, meaning that they started using computers pretty much as soon as they could read. And so they have also only used technology in ways that are very user-centered, which is very different than, say, when I first started using a computer when I was in elementary school, that my parents took me to the library, and it was all text, no images, and that it was actually a green screen, and that there was a lot of blinking lights, and it was small size. They're instead used to something that's a user-centric design. So they often expect that in their lives. They also were often raised and educated in systems where they were told to expect to have mentorship and expect to be a mentor. So that's often the relationship that they're looking for, but also to expect to have a voice, to expect to use a voice. And so that will be really critical as we think about retention. But we should know that in the healthcare arena, that it is known that people who are early career, they do have a higher risk for burnout. There's a lot of reasons for that. Some of that has to do with the feminization of the workforce and different role stress that women have, and that they have two jobs, the job at work, but also the job at home. Also some gendered expectations for listening, but it also has to do with that they have more student debt generally. They also have also are more diverse. Our efforts at inclusion are much better than they used to be, but are more diverse, and then are more likely to be minorities who then are more affected and disproportionately affected by having the risk for the minority tax, which is the term that is used to describe the other roles that people can be put in involved with family caregiving and also educational debt, things like that. But then lastly, one other thing, and not to speak overly general, make too many generalizations, but it is described in multiple venues, including in the Harvard Business Review, also in Forbes, people who do generational science, that they're often very, very values driven. It doesn't mean that everyone else isn't, but that they are too. And why that specifically is something to note, those things about millennials, is because this is, so this is what a screenshot looks like that I could find on the internet. This is not about the specific EMR, but this is what an example of one of our EMRs look like. And you can see that it's sort of, there's a lot of information in a small amount of area. You cannot contextualize it for the work for your patients. You can't contextualize it to what you need, when you need it. It's not really a very, very clean design. And this is not it. This is just the ones I can find on the internet. This one is deliberately blurry because the website had it that way. But to know that, again, there's a lot of text, there's a lot of information in a small space, hard to contextualize it for what you need it to be. And then actually I included, this is just what's on my phone. this was the screenshot, as you can see, of my dog. You can see it is what I want. I want to see my dog Daisy, but it is a very clean design. And so it's really very striking, the difference between the technology that millennials have been raised with and the technology, the way they spend their day all day, versus the technology that they have at work. And I say that because that is not an insignificant way to, not an insignificant point to understand why millennials might have a harder time, or anyone who's early career, with the technological or the electronic environment at work, is because they are used to something that is a clean design like this. It's very user-centered. So this is a nice article to think also about when we think about retention. And this was, although I subscribe to the Harvard Business Review, I suspect that a lot of you do. I think that this one is really nice. I think that the lessons that they're talking about in this article are not just about why women in their 30s are leaving their jobs, because this comes to recruitment and also retention. But very specifically, in this article, they had the results of a survey that was done, and this is a busy slide, and I apologize for that. You'll see that the top half of the slide is what are the reasons why women have left their jobs. The bottom half of the slide is the top 5 reasons why men have. And then there's a lot of percentages. I hope that you can see that I've underlined in red the same word twice, and specifically it's the word meaningful. So again, the idea, actually for our purposes today, I don't wish to highlight the gender differences, instead to highlight the idea that making sure that the work was meaningful to people was incredibly important. So we want to make sure when we're thinking about recruitment, when we're thinking also about retention, that we are thinking about ensuring that the work remains meaningful. So things to think about also, we've talked a little bit about millennials, and but now also thinking about someone who has changed jobs and come to us that way, and we've recruited them, and we want to think next how to retain them. And they may or may not be a millennial as well. But for the person who's changing jobs, I think there's a really nice way to think about that person, and to know within the context of, this is a book a lot of you have probably read called Exit, Voice, and Loyalty, and if not, or if it's been a while, briefly, this is a book that came out that really highlighted about the key to retention and satisfaction. Those key can be boiled down to 3 things. The first is that when people come on board, they're highly loyal. It takes them some time to find their voice. If their voice, it doesn't seem like it's being listened to, then that's when they'll exit. And I think that that should resonate with all of us. And within that framework, I bring up that their loyalty was tested. That's often why they left their job, and that maybe if they didn't feel listened to, or that they never found that voice. So when they come to you to know that their loyalty has been tested, so that they may be more suspicious, they may be coming having just experienced and not yet over burnout. So that sort of the really positive, wonderful, curious period when we first come on board, that may be easily shorter for them because of a negative experience. So we very quickly want to make sure that we're demonstrating how much we value them, how important they are to us, and listening to their voices. But I do know that they may end up having a higher risk for burnout, but I also want to highlight that someone who has changed jobs, looking for a new job and finding a new job is actually fundamentally hopeful, because it means that you are committed to the patients, you're committed to the community, and so that then you want this to work out. So I hope that we can understand that there is hope and there is optimism there. So with that, having covered those assumptions, then I thought we should talk about some foundations that I want us to think about as we move forward, as we think about our R&R efforts. One of the foundations is that clinician burnout is a public health crisis, but we're going to hit upon all 3 of these. I suspect that we are all in the same boat about this, but if you are struggling to understand that, or if you are in a practice that is a little bit more isolated and you think it's something just about your practice, it is not, or just about your peers, it is not. It really is a crisis in healthcare. This was a report that came out earlier this year. You can see from these really esteemed colleagues in the Northeastern United States. And I do think organizations should read this, including frontline clinicians, but also organizational leaders. Really, and in addition to our elected leaders too. If you are someone who really does understand and does believe that this is a crisis and that we really need to take action, you are not alone. The National Academy of Medicine has an action collaborative on clinician well-being and resilience. I have, on the top of the slide, I've included their website. If you take that, that URL and put it into your search engine, you will find really a treasure trove of information, not just about the scope of the problem, but also about solutions, a compendium of solutions, and we're going to be touching on some of those here. And then I think I just wanted to note that the National Academy of Medicine does say it really well, which is specifically that clinician well-being is essential for safe, high-quality patient care. I suspect that you know this, and that's why you're here, but that if you're having some challenges sort of articulating that, feel free to use the messaging that they have. So we talked in our foundations about how burnout is a public health crisis. The next foundation that I hope that we all have a shared understanding as we think about our R and our efforts is that burnout is not a personal failure, and it's generally the product of systems and culture. Some of this data that I'm going to present is a little bit familiar to you if you were able to join me in the last webinar, but I'll be very brief. Briefly, this is an article from The Lancet that came out in 2016. The Lancet is a very high-profile medical scientific journal that was looking at interventions to prevent and reduce physician burnout, and specifically showed that when we do these types of interventions, that they work. And that's really important to know because we need to have hope, and we need to know that this will work. Why I highlight this next article, which is from the Journal of the American Medical Association, and this one was in 2017, is because this one showed that the interventions that are done that are at the organizational level are actually the ones that are more successful. And specifically organizational level, including is a lot of workflow redesign, systems redesign, and then also culture, changing the culture, one that is inclusive, one that values frontline clinicians, one where people treat each other kindly with compassion, and when there's bidirectional communication between frontline clinicians and leaders, and really also between all of those groups too. And then lastly also that this was a really nice paper that was actually from last year that really solidified what a lot of us know, which is that there is an association, and specifically a negative one, between when, in this case, physicians have burnout, and that there are direct effects on patient safety and professionalism, and also on patient satisfaction. And why that, of course, I bring it up here is because we all know that the culture in which we practice is directly most significantly what affects patient safety, and then often that affects patient satisfaction. So these are really interrelated concepts and precepts. So covered a little bit of those foundations. The next one is that when we think about burnout, that we should respond with empathy, of course. We should respond with science, of course, because we're all scientists on the call and we value science. And specifically, one of the ways, of course, that we want to think about how we can do so is that we can understand that burnout specifically has been described as a betrayal of purpose. It has also been described more recently, you may have seen in some YouTube videos about as a moral hazard and moral injury. I think that it's a little bit less important what is the language than it is that we have the same shared assumptions and that we have the foundations about this is something that we need to address, that it's not a personal failure, and that it's a consequence of systems and culture, and that we're able to address it when we work together. And specifically, how we do so is we do so very methodically. And what's really nice about being methodical in how we address burnout is because it provides us the opportunity for being as methodical in how we do our R&R work. So this was a model that was developed by a group. There was someone from UVA, someone else from Mount Sinai, someone else at Stanford, Mayo Clinic, lots of different colleagues who, and lots of different specialties, who wanted to think about how we should be thinking about professional fulfillment. And at the center of the circle is professional fulfillment because it's the goal, but it's also the heart of the work. And that really just highlighting that it depends on the reciprocity. There's an interdependence, that's why they're the arrows, between 3 different features. One of them is the culture of wellness, how we take care of each other, how we feel like we're valued, all those things that go into culture. I know that you know culture eats strategy for breakfast. But then also the efficiency of practice so that the work works for us instead of us working for it. We want to take care of patients and communities, not spend our time working for clicks. And then lastly, that there always is work that we bring to it, which is the personal resilience component. And this really advises the foundations of what we're going to do for the meat of, but how will we think about R&R? So we've covered these foundations, and the last point I'll mention is that I hope that we all agree again, and I hope that that background that we just covered is that we agree that we can treat and then we can also prevent burnout. And how we do it is with science and with empathy. So this is a slide that I think is really meaningful. This was one that was, credit goes to Dr. Suja Matthew. She's an internist in Chicago, and is a product of a conversation that she had with Dr. Mark Linzer at Hennepin County Medical Center, who works with Ms. Sarah Poplow, and that they really are among the many experts who are doing tremendous research and work in this field and found lots of solutions. And to spend a moment on this, what's really important is that you can see that this is sort of like a distribution for sort of frequency for how people are doing when they have burnout and how do we intervene. So specifically, just to spend a moment on this, which is in the left-hand side, you can see that it reads about resilience and mindfulness work. So those are strategies that are important, but they really are only going to be effective when someone either has no burnout or low burnout. And then moving to the right, if someone is experiencing or an organization is experiencing anything but low levels of burnout, or even medium levels of burnout, then really what we need is systems changes. You may be able to see that that's at the top of the slide. That's where we have to implement the system, and then also the culture. But if we look way to the right, if someone is really, really highly burned out, and we're worried about things like mental health diagnoses, then really that's where psychiatric assistance is needed. And the corollary is that psychiatric assistance really won't meaningfully address low burnout or medium burnout. So I hope that we have a shared understanding that there is a role for all of these things, and I hope that we can all leave this call with a commitment to be able to think about all of those things as we move forward, and those the different problems, the different scope of burnout that requires different solutions. So again, bringing us back to this model so we can sort of recenter us for the way forward as we do our R&R work, that again, we think about the culture, we think about efficiency of practice, and also personal resilience. And now we really get into the meat of the actual R&R work that we need to do. And I want us to have a tiered approach because every person on this call is an expert in their lived experience and in their clinical environment. And some have been doing this work for a long time. Some of you I know are new to this. So I have some foundational strategies and suggestions that I hope everyone can do. And then some more advanced that builds upon those foundations, but then really the highest performing, most aspirational work that we can do in recruitment and retention to highlight the great work that we can do supporting clinician well-being and professional satisfaction. And then also flipping it the other way so that we can do great work in clinician well-being and professional fulfillment and satisfaction, our anti-burnout efforts, and how when we do that, it creates retention. It also creates recruitment because we highlight that because everybody knows this is a national emergency. They're looking for places that will value this work. So moving forward, the foundations of the work that you're going to do for recruitment and retention that is really interwoven with professional satisfaction and well-being. The first real foundation is just the promoting personal resilience. the next is to, and I'll speak a moment about that next. Next is to have a professional fulfillment and sustainability committee. You'll see I indicated an asterisk there. And the asterisk is there because you can call this your recruitment and retention committee. You can also call it your nurse well-being committee, your dental well-being committee. It doesn't matter to me. It has to be something that is authentic to you, the work that you're doing, and to your organization. One of the reasons why I indicated here professional fulfillment and sustainability is instead of R&R is because this may feel like it is more clinician-centered. For some people, talking about recruitment and retention, or flipping it and saying retention and recruitment, they can feel like that's more clinician-centered. Again, it has to be very local, but all of this work is interrelated, absolutely all of it. And if you remember nothing else from this talk, I hope that you remember that. The last thing I'll say, some foundational work, is consider having a workflow and IT usability committee. And I won't spend as much time on that, but the idea is because then frontline clinicians are giving feedback about how our workflow is going. They're advising us, and ideally this work is embedded in your R&R efforts or your professional fulfillment, wellness, sustainability committee. And before you saw the screenshots about what some of the common EMRs look like, in this case, I just thought I would highlight why the workflow and IT usability will be so important, is because although this paper you can see from the Mayo Clinic is physician oriented, this is not just about physicians. There just happens to be the most amount of data about retaining physicians. We desperately need more on nurses, social work, pharmacists, patient care technicians, medical assistants, dentists, really everybody on our interprofessional teams. And what specifically what this paper highlights is how many people are planning on reducing or are already cutting back on their clinical hours. And one of the biggest drivers of that is their burnout, and the biggest driver of that is the features of the electronic environment and their IT and their workflow. So that's why I would really ask you to embed that into your R&R efforts, your professional satisfaction and well-being. So, but getting back to some other sort of the foundations that we're going to do, two key things we'll focus on. One of them is promoting personal resilience, and that's again foundational. And then this can also and should be very local to where you are, because the challenge is very local to where you are, and it should be clinician driven. So some ideas that are really foundational to this that I hope that we can all consider. One is we're going to have meetings. Let's have, if it's a lunchtime meeting, lunch should be there. Always have healthy foods, and really try to have them in the vending machines too. It's better for the patients. It helps create a climate of health and well-being. Also to have water stations, if that really is just, regardless of the brand, or one of the little water coolers. There's a reason why people talk over water coolers. It's because we all get thirsty all day, and it just is a small way of showing that we care. Another thing is to really spiff up our workstations. So you already got to see a picture of my dog, but it is very striking to me when you go to some of the different clinical environments where we get to go, and some of them have pictures of, you know, in the pediatrics clinic where there are pictures of babies. Same thing in the midwife and obstetrics practice, that there's babies, right? Or that there's pictures of the staff. There also are things like art, plants, ideally windows, good lighting, maybe standing desks. That's going to be important to your retention when people say, what can we do? When we say, you know what, we know that we need X more number of dental hygienists, but we just can't get them now. But another way that we can show that we care is to change how people are doing the work, just with their workstations, these one-time expenses that can really help people feel, it can show that they're valued. And then also when you have people who you're recruiting, when they walk through, they see that environment. And this doesn't have to be expensive. I mean, standing desks don't have to be expensive. They pay off in droves. Framed artwork, I mean, framed posters are not expensive. Ideally, it's something that's selected by the staff. It's also maybe selected in conjunction with the patient so that it can be relevant. I practiced on the Navajo reservation for almost 10 years, and we had art that was particular and very specific for Native culture, and it was very meaningful. It restated our values, our commitment to our sense of purpose. Other things that we should not overlook is the value of having an awards and recognition program through your work in promoting retention and also recruitment. People don't need to have a national holiday named after them, and you don't have to give them a kidney. They just like when someone said thank you and they were recognized. And no matter how resource limited our environments are, we can do this. We can print off certificates. Really, if you have a computer and a printer, you can make a nice certificate and also bake some cupcakes. I mean, ideally, it's even bigger than that, but that's a great foundation. And there's so many opportunities for how we can think, how we can recognize people, and how we can improve the recognition that we're doing. Other things we can do is that if we're going to have some meetings, anyways, that we can embed some content on things that are related to our personal health. I have found that people have loved to have conversations about good sleep habits. 10 minutes in a meeting talking about that, maybe even giving people earplugs that are very inexpensive, maybe those soft eye masks to say we value your health, and you could put a logo on it or not for the clinic name or the institution name, but it makes a difference. The evidence is there for the science that it helps people. Everybody likes a good night's sleep, and then people are reminded that you care. And it's a wonderful thing to do when people are coming by for their recruitment as well. And this will give them a little like maybe baggy about self-care things. Also, if you have a little bit more resources, on-site exercise facilities are great. If you don't have them on-site, the goodwill because of the great work that you're doing, maybe you can build on that in the community and get discounts at local fitness facilities, and then help the staff know that that's available to them. Because even if they don't have a chance to use it, they love the idea that you did it. Some other ways that we can do so, that we can promote personal resilience, or having opportunities for increased social connections. Professional loneliness is real, but also we do our best work when we know each other as people. So we really need to give people time for that. And I'll talk on the next slide about that. Other things we can do is offer that mindfulness training, or even just spending a few minutes in meetings. I have a colleague who once a week, they spend the first 10 minutes in the meeting doing a brief mindfulness exercise. And if people don't want to do it, they show up 10 minutes late. So it always starts on time. It always starts with mindfulness. It always is over by, in that case, at 1:10. There's an opportunity there. And then last is we can do our best to destigmatize help seeking and also health seeking. And I'll have some more slides about that. So I hope that everybody from here does this foundational work. I will note that when we're thinking about bringing in this and integrating this type of work, that we want to be mindful of there are some things that are more effective than others. This is a nice article that demonstrated a study where they were trying to create a stress management and resiliency course with nurses, and what they found was that it actually didn't work. Some of the reasons are that nurses are highly resilient people already. And then some of it is because everything doesn't work everywhere. So we really need to do not just resiliency work. We need to change the work environment, the work culture, show people that we care. And then the retention problem can fix itself. And then we can help recruit into this nurturing environment where we know and value that people are resilient. A little bit related to that, in this case about physicians, this was an article from the family medicine literature where they talked about that very specifically, we really want to be careful about using the term resilience because it can be, there's some commentary on social media and then the internet of people feeling like when you're telling me to be more resilient, you're saying that the problem is me. And we want to be really sensitive to that because again, the bulk of the work and preventing and treating burnout is actually going to be in the systems and culture redesign. Doesn't mean it's not a role for resilience training, but it can't be the only thing that we do. And again, sometimes when we were not sure where to start, and the work starts outside of the webinar, but that if you actually open up your search browser and you just search for American Hospital Association, a call to action, creating a culture of health, this is a free PDF that was created by the American Hospital Association. And it's actually, although it's about hospitals, it's not just about hospitals. It's truly about creating a culture of health, a climate of health, and really how our healthcare institutions, big and small, all have a special privilege and a special duty to model health for our communities. So that's some really foundational work that we can do, language we can use, skills that we can adopt in our recruitment and retention work. And there's some really nice stuff in there. This is again, that the workspace will speak for itself. And I will say that, I used to go twice a month to a clinic that was 40 miles away and at the end of a dirt road, and it was a double wide trailer where there was one phone line that was also the fax line and also the line for the internet, plus the phone if the patients were calling. And so it doesn't, that was a pretty resource limited area, but yet still we brought in art so that it changed how we felt. It changed how the work was being done. So a lot of it doesn't have to be expensive. We can do a lot of things like this that you can see here with art, with plants, with good lighting, to really help the workspace be a visual representation of our organization's commitment to the workforce, to retention, while also being a tool for recruitment as well. So I mentioned before that one of the opportunities that we have is to create opportunities for social connections. And this is a really nice free article and also with a brief video about how at the Mayo Clinic they had created a sort of semi-structured interactions through having protected time in the middle of the day where meals were provided, and it was optional, people didn't have to go, but it was protected time, where they were had an opportunity to have discussions and also relationship building. And what was interesting is that people who took part in this, they actually had less burnout than people who were just given free time to catch up on work. And in this case, what they did was that the first 15 minutes, there was a specific discussion point, question, statement, comment. So it could be one about like their values, their commitment, about professional satisfaction, about professional well-being, about professional sustainability, about each other. So that again, it was semi-structured, and then after 15 minutes, it can go into whatever you wanted it to be. Of course, not a great session. This was an idea for people to connect to each other, to know each other as people. There are so many ways for us to do this, and I hope everybody on this call can consider that. It's also pretty inexpensive. Another foundational thing that we can do is to destigmatize help seeking, because there's an epidemic of substance use disorders right now, and there are also mental health diagnoses that are incompletely treated, and that includes in our professional workforce who are under a lot of stress, naturally resilient people doing a ton of work. This was an article that showed in the case for physicians that there are, when you apply for your medical license, in this article they showed that the states that are asking stigmatizing questions about having mental health diagnoses, physicians in those states were less likely to seek help. And why that is relevant is because there's a recommendation from the Federation of State Medical Boards that we not ask questions about mental health diagnoses. And specifically, if we even have to ask any of these questions at all, then instead that we talk about impairment. I will also advocate that we ask about professionalism, or like here they say, being ethical and competent. But I say that because that's the medical licensing. In my state, it's not just physicians who are asking this question, it's also the sleep study technicians, respiratory therapists, nurses. Oh my goodness, this is really coming up for nurses. And it really makes people less likely to seek help. It's really dangerous. And on this map, this was from that study, all of the states that are maroon colored are the ones that are asking stigmatizing questions. Although since this map was created, North Carolina and New Mexico and a couple others have changed and no longer do so. But why this applies to you is because you can update your credentialing documents and also your job applications to eliminate stigmatizing questions. Maybe also work with your licensing boards. You have incredible leverage because of the amazing work that you're doing. You're heroes in the community. But to work with the licensing board for nurses, for dentists, for physicians, for everyone in the interprofessional team to eliminate these stigmatizing questions. But then also what we can do is to include mental health resources during orientation to everyone and for everyone, because it shows we care about you. So, so we talked about that, some foundational work, and talked about how that includes some personal resilience, but then also, again, the professional fulfillment and sustainability and the committee. And like people say, well, where do I start with this committee and what will we do? So we'll say first is commit to creating a resourced, ideally, even if it's only a small amount of money and a small amount of time and a small amount of admin support. Ideally, it's more than all those things, but I know that you're working in resource limited areas like I am. But create a resource committee that demonstrates your organizational, your group commitment, your commitment to each other, your commitment to professional sustainability. And embedded in that is, again, be very explicit that this is also about retention because we care about you. And it's embedded in that will be recruitment also too. I would recommend that there's like a charter or a statement of your mission. Your values are going to be important to restore and maintain that sense of purpose. Also, what will be your goals? And it doesn't have to be overly metriced or overly measured, but just what we're going to plan to accomplish. And then make sure that you include new hires in that work, but also let your applicants know. And if your applicants are visiting on a day that you're having a meeting, invite them. They might really be excited to see that you are doing this work. If you're not sure where to start, and really we could spend an entire webinar just talking about how to create a clinician wellness committee, or it'd be professional satisfaction sustainability or recruitment retention. This is a free resource for you. If you go into your search engine and type in ACP, because this is from the American College of Physicians, which is my professional society, but you don't have to be a member to get this information. It's not behind a firewall. If you just go to ACP and then you search for Clinician Wellness Committee, ACP Clinician Wellness Committee, it will come up and it will be a screen that looks like this. And it's a whole page of information with including toolkits, references, resources, including your elevator pitch for how to make the case for this. Also resources for what do you do once you have a committee. And how do we support each other? But again, that in addition to the features that we mentioned before about having the committee, having the mission, goals, values, but really high performing committees will benchmark retention and they'll benchmark burnout, and how they'll do it is they'll measure it, and then they have transparency, so they report it and they say this is what we're going to do about it, this is what we're already doing. If you're not sure how you can do that, there's a really nice toolkit on this that's from the American Medical Association, although this is not, it says preventing physician burnout, this is not just about physicians. All of these tools can also be used. And this is free, it's accessible to anybody right now. If you go in your search engine, look for stepsforward.org, and then and even if you just did stepsforward.org burnout, preventing physician burnout, and it's a downloadable tool off the shelf that has specific tips, tools, strategies. It also has a burnout survey that you can download. It's a Word document, so you can customize it so that you can have it be anonymous. I know you can see in the screen in front of you, it says name, team, department, role. You can take all those things off. And then you can customize some of it, but you can see that it's only 10 questions. It's one page. Here you can see 5 of them. But again, you can just benchmark how are we doing, and then you make changes. And then you can say, good job, everybody. We did this change. This is how it helps, but this is what we want to do next. That, I don't know any clinician who wouldn't flock to an organization that is doing this. I mean, and I don't know anyone who wouldn't stay. It's tremendous to consider. So again, we benchmark our burnout, but we also benchmark our retention and what we're doing about it. And we always are transparent about the work that we're doing. So we've covered a lot of foundations about what our professional satisfaction work can be and how we weave that into our retention work and how our retention work is woven into the professional satisfaction. And that was some real foundations, even though I know it was a lot, but I know that you can do it. I'm going to get into a little bit that's advanced because I know some of you are doing all those things already, or even just most of them. So first is to make sure that we are embracing, if we want to really kick it to the next level, embrace a quality improvement mindset and also the skill set on your recruitment and retention efforts. And how you do that is with clinician satisfaction. So you say, you know what, we were losing some people, we did exit interviews, we asked them what was going on, and then we drilled down for details. And then really what we often end up doing, and then we report, this is what we found out, this is what we're doing. And then you just make changes and it's just quality improvement. And you just have transparency and reporting, and people feel listened to they will stay because they have their voice. They also are part of the solutions, and that is really empowering. And again, what we're going to do is generally, we can do the personal resilience work, but we should be focusing on processes and workflow because of this issue here, which you saw before, which is the systems changes are really when people have any level of burnout. It's not about having just psychiatric or mental health assistance. So, and of course, we know in the country, 54% of physicians, I saw one report, 65% of dentists. For nurses, it's a little bit more. In some organizations, it's 20%, but in some, it's up to 80% of signs of burnout. We need to, it's not a personal failure, we just got to do the work. So my story with the QI and how I really got into this was because I was in primary care clinic, and actually, true story is that when I was in college, I spent 3 months where I also worked in an assembly line, and it made me think differently about workflow and processes. And then when I was a primary care clinic, and we were giving out so many vaccines, and it just seemed so inefficient when the nurses knew who needed vaccines and the patients knew when they needed them. So my story was that then I worked with a colleague to create a policy that was any licensed clinician could give any indicated vaccine per the CDC guidelines. And then we did, nurses did nursing training, doctors did doctor training, nurses and MAs did MA training. And then also they did training with the front desk clerks, and we created standing orders, and that could happen. And then the patients loved it, and then every single member of the interprofessional team loved it. The clinic loved it because it helped the bottom line because we billed for the work, but also because fewer patients got the flu. But the patients loved it, the clinicians loved it, because it was just, it no longer required me to remember, and then me to put in the order into the EMR, and then me to talk to the nurse, and then the nurse to have to go get it. Because instead, the nurse knew the patient needed it, right? So they were just waiting for me. So we just made it easier. And that led me to help participate in developing this module from the American Medical Association and how you can do team-based immunization. You improve the outcomes, it's a quality improvement mindset, people love it, it's also great for the bottom line. And then you can highlight that in your recruiting efforts, and it helps keep people. Another way that we could do that is, again, is through we increase our connections to each other in communication, such as through having a morning huddle, and invite your recruits to the huddle so they can see how the team is respectful, how they communicate, how they know with each other as people, maybe how they give each other shout outs in the morning. I will say that this is also something that is free. I worked in another country in a hospital hospital and clinic that didn't always have running water, and it was generator based. So if the generator was out, we didn't have water, and we were able to do this huddle. And our every day it was interprofessional, and our teamwork was the best. We took care of each other, we took care of the patients. And this is another free resource for you to download if you're interested. A little bit more advanced, this is one that actually my husband did. He's a family medicine physician, and he thought, similarly, quality improvement mindset, I think we can do better, and I think we can make it easier in the care of our patients with on chronic opioids for pain. And this is a nice example. It can seem overwhelming, but one of the things that he just did was created a registry of all the patients who were on opioids, and that they were always seen on a Wednesday or a Friday. And so then the staff knew, the patients knew, because they knew what to expect. They weren't afraid that they were going to run out because they knew the appointment would be coming. They could structure their lives rather than just randomly finding out that the only time available is Tuesday at 9 a.m. when they're supposed to be at work or taking care of their kids. But the other thing that they did was that then when they had the registry, when the patients were coming in on that Wednesday and Friday, that they also had the PMPs, the state registry that you're required to check. They had those all printed the day before because they knew the patients were coming. So the work could be done ahead of time. The patients got better care, and it was safer. And then that's a lot of different ideas. And I know that you know this, but really when we think about how the change will happen, is that we really need to have empathy, and we know that change is hard, but that if we integrate our frontline clinicians at all levels, then that's how we retain them, and we always have empathy. And we extend that, again, bring your applicants to that, and they will want to be in your organization. So we've covered a lot of ground, and some of you are really so far ahead of this, you've been waiting for me to get to this part, which is the highest performing R&R work that we can do, the most aspirational. And it's all the things that you just heard and the additional great things you're doing. But we also, we benchmark, in this case, leadership buy-in on commitment to R&R, clinician satisfaction, and professional sustainability. because that will be what also creates longevity to the work. It really hardwires it. And then we look to see how do we have the patients start to advise this work as we do it. So keep the patients at the center. I know that you've seen a lot of resources on these websites. There's another one from that Steps Forward that is free. You can download it. It specifically is, it says it's a Word document. So I would recommend in your practice, if you're not doing this with physicians, take out the word physician and change it to nursing, change it to dentist, change it to dental hygienist, or change it to clinician, opinion of the leadership quality of their immediate supervisor. And the idea there is then we get this information. It shows that we care. It shows we are committed to transparency. It demonstrates empathy. And then it shows that it gives us the needed feedback that we need. And it shows that we really are listening. And then that's how we can do this phenomenal work that needs to be done for recruitment, for nursing wellness, for every interprofessional team member wellness, and then also for the care of the patients. And tell that when people are coming to interview, and we will have applications out the door, because they will know that their purpose is valued. And when we're doing that, one way that we could do so is to consider having, just like we have a chief financial officer, have a chief wellness officer, or maybe have a chief retention and recruitment officer. Again, whichever one is authentic to you. This was an article from Health Affairs where they make the case for why everyone should have this. And this is really critical work that we have an opportunity to do. And their job is to do C-suite level work to say this is what the organization should do, and to listen to the clinicians, to listen to the retention, and to really promote the work that is already being done. And so it's a real opportunity. And so it's a lot of information in a short amount of time. No matter where we are with this, we need to celebrate the successes internally. I recently had a fantastic experience visiting some clinicians at Crusader Health in Rockford, Illinois. And one of the things they had done was that they had created a process for nurses to manage refill requests. And they had filled that nursing had done like 14,000 prescriptions in like 6 months. So we really present that information then, and how beautifully they did so. They did the work, and then they presented it back to the staff so that the team can know, look at this amazing work, and then you've been listening to us. It was so inspiring. But then also we should celebrate those things externally, because that is part of our recruitment effort. And so social media will say, like, this is what we did to have standing orders for this. This is what we did to have dedicated time for people to get to know each other as people. This is how we've changed our workplace. This is how we've changed our workstation. Put it on the website. Also, what are your values about clinician well-being? Because your applicants are going to be looking for this. It should be on your printed materials. It should be also in the break room, right? Because when you're going to show it to them, then they can see it's front and center as we care about our clinicians. Have it in the waiting room. I mean, you want to, of course, the messaging is going to be a little bit different, but like so that they know that your patients also know that they are as cherished and valued as are their clinicians, and that their clinicians then will stay, because that's what the patients, they have so much trauma about clinicians leaving. And then also put it in the newspaper. And again, just be transparent. We'll always want to be transparent that the work is ongoing and that it's clinician driven. So that was a lot of information in an hour. I hope that it was helpful. I'm tempted to say, so what will you do next? But I know that in our last few minutes that I should instead say, what questions do you have? And say thank you for your time and for your commitment to recruitment and retention for our communities that are underserved.
Wonderful. Thank you, Dr. Barrett, for that presentation. And I mean, that was a lot of information, but a lot of like actionable information and suggestions on next steps, which is super helpful, I think, for a lot of us on the line here. I know we have a ton of people online, but we do have a couple of minutes left over for some questions. If you have any questions, please pop them into the chat box or the questions box. Or if you need to just take some time to digest this information, then you can reach us, any of us, via email. And we'll be emailing this information out to you tomorrow morning, I hope. So while we give some people a couple of minutes to get their questions out into the questions box, I wanted to bring back to a conversation that we were actually having just before we jumped on the line, a wellness idea of working with therapy dogs. I didn't know if you wanted to elaborate on that a little bit, Dr. Barrett.
I'm so sorry, because I missed one of the words that you said. You said the wellness, I'm sorry?
Oh, sorry, a wellness activity, I guess, to work with therapy dogs.
Yes. Oh my goodness. That was something, because thank you for reminding me. I work with a lot of people on this, and I've done a lot of work in this realm for years. And so, and it's so hard to figure out how to meet everybody's needs. But one of the things that has been universal that I should have included in the slides, and thank you for reminding me, is that no matter how advanced or how new people are to this, and how excited they are or how overwhelming it is, and you mentioned just the prospect of maybe just inviting therapy dogs one day to clinic, everyone bursts into a smile and says, that's what I want, that's what I'm going to do, and it starts tomorrow. And then people are still talking about it years later, about how wonderful it was. So we can do it more often than years, right? Do it pretty often, but I love that you reminded me, because that's low-hanging fruit that people just love. Oh, you know what? And I didn't say this before, but also I'm bringing in chair massage in the middle of the day. I'm blocking out like 10 minutes of chair massage at lunchtime is something also that people love, and it's not expensive at all.
That's fantastic. I mean, I'm taking notes and thinking about how we can work that into our workplace here. That just sounds like a really good idea. We have had a couple of questions come in, and we do still have a couple of minutes. So if you have questions, pop them in to the chat box, everybody. But somebody asked, are there any organizations willing to share the Chief Wellness Officer job description? Do you know of any job descriptions that have been posted somewhere that we could direct people to now?
I do. I will say that I don't work for any of them, but I'll say one of them is Stanford. And so if you in your Stanford, if you looked in your browser for Stanford Chief Wellness Officer, there's also Mount Sinai. That's Jonathan Rip. And then also I think Bellin, Bellin Health System, I think has one too. And honestly, if you probably even just search Chief Wellness Officer, then you'll come up with a few, because it's pretty new, but I keep hearing about a few more coming in, and honestly, oh my gosh, it's not public yet, but my institution is also creating one too, so that won't be as helpful. University of New Mexico, because we don't have those documents publicly yet, but those are a couple to go to, and maybe if that, I'm going to apologize because I didn't put my email up here, but that my email is ebarrett. That's probably too much to include. Actually, maybe we'll just go back to the first slide that has my Twitter handle. And if you on Twitter find me, then I would be able to also send you some more about that. Or if you wanted to email me, then ebarrett@salud.unm.edu.
Great. Yeah, and if there is anybody on the line who, while we were talking about this, is like, oh, that's us, we have that position. If you are able to share that information out, you can either email Dr. Barrett or myself or anybody at the STAR Center team, and we'd be happy to share that out with everybody via email or post it on the STAR Center, just so that we can give people ideas so that they can maybe implement this position in their organizations. Okay, and while we're working our way back to our contact information, I'm going to do a little bit of a wrap up here. This is our last session in this Burnout 201 series. We've been really happy to have you all with us through the last 6 sessions. Like I mentioned at the top of the call, we will be sharing out the recording and the slides for this presentation via email tomorrow. I'll also share out links to all of the previous sessions in this series. So there's Dr. Barrett's contact information and Twitter handle. Please connect with her there, and we'll hope to have you all back with us for future webinar series. Great. Thank you all for joining us today, and we'll hope to see you soon. Thanks. Bye-bye.
Thank you.